Good evening, everyone, and welcome to a new webinar as part of the Innovation and Precision Eye Health webinar series organized by the Department of Ophthalmology at NUS and the Center for Innovation and Precision Eye Health. I'm Ray Najjar, and I'm a visual neuroscientist and assistant professor in the Department of Ophthalmology at NUS. I'm also a research scientist at the Singapore Eye Research Institute and the founder and organizer of these webinar series together with Shalini. So before I introduce our speaker of the day, let me just give you a few pointers. If you haven't done so already, please make sure to enter your registered full name. Also make sure you are using the same email address you used for the registration, and this is important for the CBE and CME points. All participants will remain muted, and if you have any questions, please use the Q&A feature at the bottom of the page. Also keep an eye on the chat feature at the bottom of the page. We will be using it to provide you some logistic information. So without further ado, today it gives me great pleasure to welcome Professor Nathan Congdon as speaker in our webinar series. So Professor Congdon really needs no introduction, but I have to do it to stick to the template of our webinars. So he received his bachelor's and master's degree in Oriental Studies from the University of Princeton and Cambridge. He did his medical and public health education in ophthalmology training at Johns Hopkins University. Today, he is the Ulverskorth Chair of Global Eye Health at Queen's University Belfast and Director of Research and North Asia Advisor for Orbis International. He is also a visiting professor at Zhongchang Ophthalmic Center in Guangzhou, China. Nathan is actually fluent in written and spoken Chinese because he spent a lot of time in China, nearly 10 years, if I'm not mistaken. His current work involves the design and evaluation of high-quality, low-cost models of eye care delivery in areas with limited resources, especially in low and middle-income countries. He increasingly focuses on trials assessing the impact of vision on development outcomes. In addition to other recognition, Nathan has received the Asia Pacific Academy of Ophthalmology's highest prize for blindness prevention work in 2009, the 1,000-Man Plan awarded in 2011, and the Wellcome Trust Investigator Award in 2021. His research has been published and supported by worldwide recognized organizations in journals like Lancet, Global Health, BMJ, and JAMA. So today, Professor Congdon will be speaking about his research program called ENGINE, which is an acronym for Eyecare Nurtures Good Health, Innovation, Driving Safety, and Education. So without further ado, Professor Congdon, thanks again for accepting our invitation, and the webinar is yours.
Thanks very much, Ray. Hopefully I'm audible. Let me know if I'm not. This is somewhat in the format of a lecture, but I'm hoping that this can be more of a dialogue. I'm interested to learn from you as any possibility of your learning from me. And I do want to say that I'm thrilled to accept this invitation. I've had the opportunity to begin working recently with Ray and with his colleague, Professor Xiaoxiao Mei. We're doing some very exciting work about possibly coming up with a society-wide approach to reducing the myopia burden for all of Singapore's children. The organizations, the researchers at SERI and NUS in Singapore are world-renowned as being some of the absolute top eye researchers in the world. It's fantastic to have an opportunity to engage with you talking about some of my work, but more excitingly, I'm looking forward to our doing some projects together. So a dialogue, I'm going to talk to you some about what I do. Very interested to hear your thoughts and questions. ENGINE is at the center of the work that my teams are doing these days. And it is ultimately a series of trials that are designed to try to answer the question for policymakers of why. Why should governments and industry and anybody else invest in eye care? Usually, we don't spend a lot of time thinking about vision care, and often that's because ministers of health feel I need to be worried about COVID and HIV, AIDS, and diabetes and hypertension. Eye care is very low on my list. ENGINE describes a series of trials designed explicitly to answer that question. Why should we invest in eye care? And the answer is because we can provide high quality trial data to prove that it matters, to prove that vision care can help to accelerate progress towards the Sustainable Development Goals. And that's what we're going to talk about today. So by way of background, we've been doing trials, my team has been doing trials for nearly a decade now around SDG issues. We did the Seeing is Learning trial in China that was published in BMJ about a decade ago. The first trial to show that providing kids with free glasses can improve educational outcomes. And that's helped to drive national children's myopia control programs in China. So there's been clear evidence that vision care matters to help kids to do well in school, and that evidence has made a real difference to policymakers. The PROSPER trial in India, I think probably some of the most important work we've done, that was published in Lancet Global Health in 2018. It was the first trial ever to show that eye care improves work productivity, and it's led to statewide programs in Assam, with a growing number of companies also delivering workplace glasses in the coffee and tea sectors in India and Africa, textiles and other places as well. Again, that trial showed that there was the potential with high quality evidence to drive investment in vision care, both in industry and in government. And then finally, the Lancet Global Eye Health Commission, which came out in Lancet Global Health in 2021, had a major focus on eye care and the Sustainable Development Goals. These three pieces, we could say, are the three legs on which the engine is based, our thinking about engine. So engine is funded by a £3 million investigator award from Wellcome Trust to myself at Queen's in May of 2021. My co-PI on this award is Rohit Khanna at LV Prasad. LV Prasad is our crucial partner in all of this work and one of the top research and service delivery hospitals in the world. They were recently ranked in the top 10 out of 500 just on the basis of their research, let alone all the high quality eye care they deliver. We had £500,000 matched from the Chen Yat-sen Family Foundation and additional support from Clearly for Communications work. These slides, all of our communication stuff has been done for us by Seven Hills with that funding. So close to £4 million altogether. The trial, the set of trials that constitute engine, which, as Ray said, stands for Eye Care Nurtures Good Health, Innovation and Driving Safety. It is principally about assessing specific ways in which eye care, which delivered at crucial times across the life course, can help to accelerate progress towards the SDGs. There are 4 component trials in 4 countries. I'll speak about each of them today, and they're carried out crucially through strategic partners. These projects are delivered and in many cases co-designed together with the policymakers with whom we're trying to have a dialogue. Crucially important to what we're trying to do. We want to meet policymakers where they live and make sure that we're providing the data that they need in order to drive investment in vision care. We have governance arrangements. Our lead partners are Queen's University Belfast, and as I mentioned, LV Prasad Eye Institute in India with Rohit Khanna as PI. We have a total of 29 partners in this organization, and trust me, when you sit down to do an MOU with 29 partners, you realize 29 is a big number. That includes government ministries, ministries of health, ministries of education, ministries of transportation. It includes universities in 6 different countries. A lot of the work that we're doing involves NGOs, crucially important in connecting us to communities, patient groups, companies. We've got a broad representation of people from a number of different settings. We have an executive steering committee called Engineers that coordinates trial management groups and trial steering committees for 4 different studies that are all looking at the impact of refractive care. Clever in India is looking at the possibility of slowing cognitive decline, preventing dementia. Stable in Vietnam is looking at improving motorcycle safety. Vehicle crashes are currently the leading cause of death between the ages of 5 and 29. Thrift in Bangladesh is trying to promote mobile banking, a huge game changer for older people in Bangladesh, but you can't take part if you can't see your smartphone, which about 75% of the folks there cannot, the beneficiaries that we're trying to benefit. And then finally, Zeal in Zimbabwe, looking at better learning opportunities for kids. I'm going to talk about each of these trials and also talk about some of the other things that Engine is designed to do. Besides delivering 4 trials, we're also doing a lot of work in capacity building. We have 6 students from partners in the 4 countries who are currently now studying for PhDs in public health at Queen's University Belfast. 17 students have already received their PG certifications in management and leadership, going back to their organizations as leaders. We've got 2 clinical fellows in pediatric optometry from Zimbabwe who have now completed their training at the LV Prasad Eye Institute in India. And we're in the process of founding an injury research center at Ho Chi Minh City School of Public Health in Vietnam. So a lot of capacity building is happening as a result of this funding. I also, before I launch into a discussion of the different trials, I want to step back for a minute and ask a very specific question, which is why glasses? Why are we looking at glasses as opposed to glaucoma or cataract surgery or diabetic retinopathy? To be practical, trials like these depend on very high rates of eligibility. The majority of the target populations needs either near or distance glasses in these settings. So the kids that we're working with who are driving motorcycles in Vietnam, a very high proportion of them need glasses. 60 to 80% of the older people who are the beneficiaries of our study, the CLEVER study in India, need glasses. If we tried to do these studies with less common conditions like diabetic eye disease or glaucoma that maybe affect 4 or 5 or 10% of the population as opposed to 25 or 80%, we would have studies that are 10 times as large, and we'd have budgets that are 10 times as large. Not practical. It couldn't be done. We had to deal with common eye conditions, and refractive error, uncorrected refractive error is the most common of them all, especially presbyopia. Also, refractive interventions are the easiest to scale up in low middle income countries. They're relatively cheap to deliver. The training is relatively modest. It's important, though, to recognize there's no biological reason that the evidence of beneficial impact of vision care that we're going to get out of these trials applies only to glasses. Ultimately, these are vision studies done with the most convenient and easiest to deliver of all vision interventions, but they're not just refractive studies, and they're telling us something important about the impact of vision. So moving on, you can see that each of these has got their own logo, and they've all got their own acronym. I'm keen on acronyms. So CLEVER stands for Cognitive Level Enhancement Through Vision Exams and Refraction. That's being done in India. There's strong evidence that vision loss and cognitive decline, that those march together in longitudinal studies. If your vision gets worse, at the same time, you're going to see a decline in cognition. There's a lot of different reasons that could be. It could be that people are not performing as well on vision charts because of cognitive problems, or maybe their vision problems are causing them to perform poorly on cognitive testing. Our hypothesis, though, is that there is the vision takes up a lot of the bandwidth in the brain. And if that bandwidth is being used poorly with a high noise to signal ratio, that's going to take up bandwidth that could otherwise be used to remember what day of the week it is and figure out how to start your car. However, we need trial evidence. We want to show that our hypothesis that there's cause and effect and that glasses can treat the dementia problem, prevent dementia from occurring, or slow the pace of cognitive decline, you got to do a randomized control trial. There's no other way to do it. India is currently spending about 1% of their GDP on dementia care, a huge burden. And there's no affordable treatments or prevention strategies that are appropriate for low resource settings. So this is the rationale for this. It's an important problem. we're missing the evidence, and there's never been a randomized controlled trial looking at this question of whether vision can help with cognitive decline. It's very exciting that this trial is occurring first in India and not in the United States or the UK or somewhere else. So by way of background, LV Prasad has done an APEDS population-based study that shows to 60 to 80% of people in our target group, folks over the age of 60 that are living in peri-urban areas around Hyderabad, need either near or distance glasses. So it's a huge unmet burden. And it shows that if we have a positive trial, the large majority of people over the age of 60 can benefit from these findings. Our hypothesis is very straightforward. We think that free glasses can slow the rate of cognitive decline among folks who are normal at baseline, as measured on the Lassidad Cognitive Questionnaire, which was developed for use in India, and who have normal hearing at baseline as well. That's the basic idea behind the trial. That's how it's being designed. We have partners that are well placed to drive policy in India. We have the leading dementia patient group, ARDSI, is involved, some of the foremost Indian dementia researchers as well. And crucially, the current Indian national strategy for dementia has as its linchpin, has as its center, the desire to seek low-cost preventive interventions. So glasses are ideal for this, $4 to $5 a pair. They can be made available for that total cost. If this is proven effective, this will dovetail perfectly with Indian national government policy. India currently has a national policy of vision screening for all children. And if we have a successful trial, we would like to see that extended to older adults, as happens in the UK, a number of European countries, and perhaps in Singapore as well. STABLE stands for slashing two-wheeled accidents by leveraging Eyecare. Again, you got the acronyms going on here. Again, there's a rationale for this, a reason that we chose to do this particular trial in this particular place. Traffic crashes, as I mentioned before, the leading cause of death globally between the ages of 5 and 29. That's a crucially important demographic. If you think about a country like Vietnam or a country like Singapore, for that matter, people between the ages of 5 and 29 represent the hope for the future. When one person like that is killed in a traffic crash, their family, their community, their school, there's a massive ripple effect on society. Currently, 90% of traffic crashes occur in low and middle income countries, even though only 60% of the cars are there. So it's a major scourge, a major healthcare problem for LMICs. There's very little published evidence that central vision matters for crashes in rich countries. And in fact, there's a reason for that. There's just recently come out yet another review saying that vision doesn't matter for driving. That's because that review was done almost exclusively looking at studies from high-income countries. We do a very good job in rich countries of keeping people off the road who can't see. Further, most studies that have looked at driving problems in high-income countries have generally focused on older drivers who have a lot of other issues like slow reflexes, and it's not clear that glasses by themselves will help. Our team, Prabhat Piasena et al., have recently done a review in Lancet Global Health that in fact shows in lower middle income countries, the situation is very different. Many, many drivers have poor vision in these settings, including drivers who are professional drivers. Their vision impairment is associated with about a 46% increase in the risk of crashes in the meta-analysis that we did. And crucially, this review showed a major policy failure when we asked drivers, so how did you get your license? Didn't you fail the screening test? Two-thirds and more would say again and again, what vision test? So there's policies on the books that people should get vision tested before they get their glasses, or before they get their driving license. But in fact, that's not happening in a lot of LMICs. Vietnam has twin epidemics. They've got uncorrected myopia, a situation that's similar to what it is in Singapore, should be familiar to you. They've also got an epidemic of motorcycle crashes. 50% of all global motorbike deaths occur in Southeast Asia, and Vietnam is leading the way. About 90% of all vehicles that are driven in that country are motorcycles. There's never been a randomized control trial of vision care and traffic safety in an LMIC. So crucially important to get this trial done. Our hypothesis is fairly straightforward. We believe that providing myopic young motorcycle drivers recruited at universities in Ho Chi Minh City with free glasses will reduce crash and near crash events as recorded by GPS and a gyroscopic sensor video data acquisition system. So basically, we're going to put small cameras and small gyros mounted on all of these motorcycles. The gyros will mark the video when a swerve or a crash or a turn, an unsafe event has occurred. We'll analyze those videos, and we're looking not only for uncommon crash events, but also for much more common near crash events, dangerous riding behavior. This design is a stepped wedge trial. We want to avoid withholding care. There's not ever going to be a situation where someone is examined and not given glasses. There's going to be 5 cohorts of 175 drivers, so we're talking all told about 750 or 800 people. Each cohort is going to be examined sequentially at 3-month intervals, and those who need glasses, between 20 and 25%, we estimate, will get them, and then we'll enter the intervention group. Their prior data will be analyzed as control. The remaining people who don't need glasses were never enrolled in the trial. So a substantial number of folks will be followed who will not actually end up being in the trial. The only ethical way we felt to do this study. Monitoring of natural driving is crucial in this setting. We can't just go in and look at records of crashes, because often crashes that occur are not adjudicated formally. Somebody hands somebody a wad of money and that's the end of it. Very common in LMICs. So we have to look at naturalistic driving. And excitingly, naturalistic driving studies depend on miniaturization of cameras, massive and very small hard drives that only recently have become available. This is one of the first generation of new studies that really only could have happened in the last few years due to miniaturization that's been driven by development of smartphones. We owe a lot to those guys. So our partners and potential for impact are a particularly important and exciting feature of this study. Our main local partner is the Traffic Policy Wing of the Ministry of Transportation, TDSI. We're also working with the Asia Injury Prevention Foundation, and together AIPF and TDSI have deep experience with policy change. They were the authors and the ones who got passed a recent helmet law. And you can see from the picture here, it's working great, right? Everyone you can see in that picture is wearing a helmet, and that's true. Been a significant reduction in deaths as a result of those helmets. So these are experienced policymakers. The agreement is that a successful trial is going to lead to tougher vision requirements for licensure. Currently, if you get a doctor's letter without even having a vision exam, that's sufficient for lifelong licensure. We want to see that changed, and TDSI, they're the policy wing. So it's been very exciting working with them. At every step of the way, they have taken a crucial role in the design of this trial. We were going to design this to enroll only men, because 80% of crashes involve men. Ministry of Transportation told us it's going to be much easier for us to achieve policy change these regulations, if we have data that include women as well. So a decision was made to redesign the trial based on input from policymakers. And I'm a strong believer that's how it should be. In doing research, our goal is not to publish things in Lancet Global Health and talk to each other as researchers. Our goal is to achieve policy change. It's only going to happen if there's a dialogue with policymakers from the very beginning, so that we're certain we're providing them the data that they need. THRIFT, the next trial in our series, stands for Transforming Households with Refraction and Innovative Financial Technology. Bangladesh has recently moved all social safety net payments for the elderly online, partly in response for COVID. It's great stuff. That means that older folks don't have to wait in front of the bank anymore. They don't have to worry about getting jumped and having their money stolen on the way back. They don't have to worry about going to the bank and getting COVID on the way home. A lot of great reasons for this. Problem is that pilot work by our local partners shows that about 3/4 of potential recipients of this elderly benefits can't actually see a smartphone in order to use one. And that's consistent with our prior published work on presbyopia, corneal vision, as a barrier for smartphone use in other lower middle income countries such as China. It is a big issue. Smartphones are a fantastic gateway to the world. Huge potential to use this as a tool for healthcare. But as long as older people, who are often the most important beneficiaries, can't see a smartphone to use it, the impact of this tool is going to be limited. Our hypothesis is pretty straightforward. We think that giving free near glasses and a simple training in smartphones, an hour on how to use a smartphone, will result in greater financial inclusion. That's our main outcome, people's ability to access these accounts that the government has set up for them. More transactions, more traffic in terms of money. But the secondary outcomes are also very exciting. As people have improved financial inclusiveness, improved ability to access their money, we believe we'll see differences in impacts on food security, COVID-safe behaviors, reduction in loss of funds due to theft and fraud, and application usage through agents and family members. So we're looking at a number of different outcomes here, but in particular, financial inclusiveness as a result of having better access to their own bank accounts because they can actually see their smartphone to use it. Once again, there's a significant opportunity with this trial to affect global policy change. The World Bank and other multilaterals have taken a strong interest in Bangladesh's model. Bangladesh is a very progressive country, always has been. They used to say back when it was part of India, what West Bengal thinks today, India thinks tomorrow. So Bangladesh is a global leader in this area. World Bank and others are very interested to replicate the Bangladesh model of online social safety net payments to the elderly. We hope that if we have a successful trial, that the use of vision services nested into these online banking models can be replicated as well around the world. And so it's an exciting opportunity, and we're working with World Bank. We have some members of World Bank sitting on our trial steering committee to try to make sure that these results are disseminated to the key policymakers. So ZEAL is the fourth and final one of our trials that I'm going to talk about today. It stands for Zimbabwe, Eyecare, and Learning. There's strong trial evidence that provision of myopic glasses improves children's educational outcomes. We've done a number of those trials in China, and there's no question. One of the, in fact, the existing evidence is stronger for the ability of vision care to improve school performance than for any other school-delivered healthcare intervention. Things like deworming and iron and things like that. There's also, though, growing evidence that uncorrected hyperopia or long-sightedness may also be associated with impaired learning. And it's not a crazy idea. You have difficulty seeing things close up, like textbooks and reading. There's no trials that have been done in the area, and most school vision screening programs currently test only distance vision. That's not going to identify hyperopia. And under current methods, hyperopia is quite resource intensive to detect. The available evidence suggests that the prevalence in Africa of hyperopia is higher than any other world region. So a number of reasons why we want to be doing this study in this location. ZEAL uniquely is not a randomized controlled trial. It's actually formative research, and it's designed to answer three main questions to potentially support a later trial. First of all, how common is hyperopia among kids aged 6 to 7 and 9 to 10 years old that are participating in Zimbabwe's national vision screening? We're going to perform full cycloplegia on 2,000 kids as a gold standard. In fact, this work has already been completed. We also want to find out how accurately novel, low-cost tests can identify hyperopic kids. We obviously can't go through and do full cycloplegia for every kid. It's not practical to do that as a national screening program. We're using some variety of low-cost tests to try to validate and find out whether they can be used to pick up hyperopic kids. Laser-etched eye charts designed to be used at very near distances, like 12.5 centimeters, that are most challenging for hyperopic kids. You got to have 8 diopters of accommodation to see these charts. There's a recently developed PASS test of stereo acuity, and we're also looking at measuring accommodative range with an inexpensive portable autorefractor, the Bruckner reflex test, a number of low-cost tests to try to prove whether we can pick up hyperopia cheaply. And then finally, and most importantly, we want to determine whether reading levels of hyperopic kids measured with a Zimbabwe-developed Happy Readers tool are actually lower than for non-hyperopic kids. A lot of this work has been completed. We've recently been funded to carry out a large trial in Sierra Leone of providing glasses to kids to see whether we can improve their academic outcomes. We'll be looking specifically at hyperopic kids in Sierra Leone as well. So increasingly over the next couple of years, we're going to have a lot of data about refractive error, school performance, and hyperopia among African kids. There's clear opportunities for policy change here. This particular trial, ZEAL, is being done with partners who include the major implementers of Zimbabwe's current national school vision screening program, the National Optometric Society, School of Optometry, and NGOs CBM and Peak Vision. The goal is to incorporate hyperopic screening and correction into this national program in Zimbabwe and potentially in other countries as well through CBM and Peak Vision, depending on the results that we have from ZEAL and from later trials. So in terms of our directions moving forward, we've got some pretty ambitious goals for this. And I would say the main idea is that the eye care sector does not have an exclusive copyright on low-cost, life-transforming, underinvested health interventions. We're working now with LV Prasad to form what's called a Wheel Institute, Wielding Health as an Engine to Enhance Life. We want to look at and generate policy-relevant evidence to drive investment in other low-cost, friction-removing wheel interventions across other health sectors, including hearing, dentistry, women's health, pulmonary medicine, health packages to improve productivity of agricultural workers. Basically, this engine idea is going to be replicated more widely across the healthcare system. It's the basic idea. Happy to talk with you in more detail about that. LV Prasad will be a crucial part of that, and their existing infrastructure of nearly 300 vision centers across 4 states will play a crucial role in delivering these trials. So I'd like to finish by acknowledging the supporters that have allowed Engine to move forward, the Wellcome Trust, the Chen Yat-sen Family Foundation, and Clearly. And we're funded by the grant reference number here from Wellcome Trust, the main funder of this study. Finally, I'd like to acknowledge the Engine team, both at Queen's University Belfast, but also crucially at LV Prasad Eye Institute, our main partner for carrying this work out. The Clever team, including investigators in India and in other countries, including the United States and the UK. The Stable team, partners largely in Vietnam, but also including partners in other countries, international partners from traffic safety specialists to epidemiologists to health economists. A lot of the work we're doing is looking at health economic analyses to show the cost effectiveness of these analyses, of these interventions. The Thrift team in Bangladesh and internationally, and finally the ZEAL team in Zimbabwe with international collaborators as well. So I'd like to thank you very much for your attention. If you have questions about Engine, I'd love to hear them. I'd love to have an opportunity for dialogue now. And saw we had 250 guests there initially. So, you know, if you don't have a chance to answer your question, drop me an email at ncongdon1@gmail.com. We've got 29 collaborating institutions. We're always looking for new collaborators to bring forward this kind of work, the work in Engine, the kind of work we're doing on red light with Ray and his team, always looking for new collaborators, always keen to hear new ideas and new questions. So thanks very much for your attention, and happy to turn this over to our audience for questions. And Ray, you maybe have been looking at the sort of the chat there. I don't know if we have any questions that have come up, or if we're going to have folks raise their hands, or how you'd like to proceed with the questions. So we got plenty of time for questions.
Let me first, Nathan, start by thanking you for telling us about all these fantastic projects. And yes, we have a question section, we have discussion section at the moment. So, but before we start with that discussion, I'd like first to invite my colleague, Dr. David Chen, who is an associate consultant in the Department of Ophthalmology at the National University Hospital, to join us as a panelist. David is one of our department's fast-rising clinician innovators. He's interested in ophthalmic imaging, medical technology, and anterior segment surgeries, but also in community eye care. So, David, thank you for joining us. I understand you have already a question.
Thank you, Ray, for the introduction, and thanks, Nathan, for that nice presentation. I actually have more than one question.
Good.
But first of all, let me just thank you for sharing this very, very meaningful series of researches that you are doing. And as a refractive surgeon, refractive error is one of the areas that I really am very passionate about, not just on the myopes, the hyperopes, but also the presbyopes. So perhaps my first question to you is, reducing this correctable vision loss in the specific countries that you look at clearly has a great need, and we are looking at how we could impact them through cost-effective means. Beyond this, projects that are currently funded to achieve these goals, can I check how you foresee the long-term sustainability? We have proven that glasses could help, but who will be the payers who come in to make sure that the population receives this kind of correction? Yeah.
Fantastic question. So I would say that the studies that we've done so far over the last decade point a way forward, David, in terms of how this can be paid for. In China, the government is expending hundreds of millions of dollars to try to manage and prevent myopia. Some of those resources need to be devoted towards the treatment of existing myopic kids. In order to try to drive that, we're about to start on an RCT, a new RCT in China called SWISH. So we've already demonstrated that we can improve kids' grades, their academic performance, by giving glasses. We now want to look at a more important life-changing issue. Kids who, the question of whether kids go on to high school. So currently only about 50% of rural kids in Western China attend academic high school. If they don't go to high school, they've missed that economic train that's taken off, in the station in China, because they're not going to go to university. So we hope that additional data can about the importance, the life-changing importance of providing spectacles to children, can help to further shift the dial. The Chinese government has shown a strong willingness and interest in investing in this area. We'd like to see some of that investment go not just towards prevention, which is important, but also at the same time, some of it going towards increasing refractive services, training better and more refractionists to provide refractive services. With respect to adults, the work that we've done already in Assam with tea pickers has resulted in very significant corporate and government investment in these programs of delivery of glasses. We want to see more of that. So what we're doing right now, we're working in the textile sector. We have trials that are ongoing now to look at the impact on not just on productivity, but workplace retention. When we look at the textile sector, we see that, interestingly, participation drops off heavily at around ages 35 or 40. Now, it could be that those folks are getting too old and tired to work, but our hypothesis is that, in fact, that's when presbyopia is coming on, and that those folks are losing those jobs. We're testing that hypothesis by doing an RCT, following people out for 18 months, and seeing whether workplace retention can be increased with glasses. Then you're not just giving somebody a 25 or 35% bump in productivity, like what we saw in our Prosper T study, It's going from 0 to 100. There you have potential investors in industry. Patients themselves, actually, in the T factor, we found 85% of folks, no more, 95% said they would, in the tea plantations, if they lost or broke their glasses, they would invest to get a new pair. They saw the impact on productivity. And then, of course, governments potentially have a role as well. So I think we see a number of different investors that can help to sustain these things. And what we need to do is feed and drive that investment with more and better quality data. We're going to be starting trials soon on adult literacy. We think there's a strong impact, strong connection between provision of glasses and successful adult literacy programs. Workplace participation rates are dropping over the age of 50 throughout the lower middle income countries as the agricultural sector is contracting. And we think that successful adult literacy programs are a big way of preventing that, solving that problem. That's only going to happen if there's investment from government, investment from industry. We're going to do trials trying to show that that investment will have real measurable economic benefits. So all of our work, I would say, David, is designed at answering that crucially important question that you asked: how will this be sustained? And our answer is it'll be sustained by showing high quality evidence to governments, industry, and other key people that are in the position to sustain these things. And the great news is we're not talking about purchasing MRIs or expensive laser machines here. We're talking about purchasing $4 or $5 items, the full cost of delivery, around $4 or $5. I think it's all very manageable. So that's how I would see it. It's we think that the investments that will sustain this will be driven by key stakeholders, and we've already shown the ability to drive that investment with more, better quality data, showing that it's worthwhile to make those investments. And we want to now expand that into areas like dental care, hearing, other things. We're starting in Clever now with folks that have screened out of Clever. We're doing a pilot for another trial that will look at the ability of hearing care to stave off cognitive decline. We're interested in doing trials about how dental care, low-cost treatment for edentulosum, can improve the nutrition and therefore improve the productivity of older folks. So again, it all boils down to looking at outcomes that those who have the money to drive these services care about, and those tend to be economic outcomes.
Thank you, Nathan. I can follow up maybe with one question. So I was wondering, Nathan, if there are studies looking into the individual's understanding or perception, for example, for your stable study, right? Are motorbikers complaining? Do they have a perception that if they have uncorrected vision, they are less confident driving a motorbike? The same applies to your other studies as well. So with thrift, are they less confident operating? Do you have feedback from these participants initially before treating them?
So it's a great question. And we have a couple of researchers on our team that are driving the specific research about measuring and encouraging glasses compliance. It's one thing where glasses are less convenient than something like cataract surgery or refractive surgery. Somebody comes in and remodels your cornea or puts an intraocular lens in, you can't forget and leave that intraocular lens sitting on the table, the bedside table at home. Glasses, there has to be a willingness to comply and adhere with those things over life. So there's several different things that can drive that. We've shown that in the workplace, if we can demonstrate and show workers and companies that their productivity improves, that they will definitely comply. So workplace, we think it's self-reinforcing. In schools, it's not self-reinforcing. A lot of kids don't wear glasses. They just don't, Remember the first project I ever did as an NGO worker, which I've been doing for about 20 years now, I worked with Helen Keller International, and everyone loved our project of getting free glasses to kids, except the janitors. The janitors hated it. They had to climb up on the roofs of the schools and sweep off all the glasses that the children had thrown up onto the roofs. So what we've come up with as a way of beating that problem is we incentivize the teachers. Teachers are incentivized with modest payments, free glasses for themselves, other things. We come back in, we check and see that kids are wearing the glasses. If 80% of the kids are wearing their glasses in unannounced checks, the teachers get a small gift. And then that can be built into their salaries, as is happening in China now. So you have to build in incentives there. I think when it comes to traffic safety, one of our big interests is in traffic safety in Vietnam. Drivers, wearing their glasses. We're testing adherence with the cameras. We actually have a little camera that's mounted looking at the driver to see if they're adhering. And we know that, if you're doing something for a long period of time, you tend to forget that you're being examined. But there, I think it's going to have to be policy. I think it's going to have to be the government that says you need to be wearing glasses. And, if you're not wearing them, then you get stopped, you get fined. That's been very successful in high income countries. So our goal, ultimate policy goal in Vietnam, is that whenever you come in to do a vision exam, if you fail, you're going to get told not, Ray, I'm sorry, I guess you just lost your job as a driver, but rather, Ray, no problem. You have an appointment in room 12 down the hallway in 15 minutes. Go down there, be examined, get your free glasses, come back, we'll test you again, and then you get your license. And then that becomes a platform to get vision care to a very important economic segment of society, which is drivers. We currently don't do a good job of reaching that sort of 20 to 50 group. Old people come into hospitals, young people, will get them in schools. Drivers, I want to start getting them at the point of service where they're getting their vision exams done. So there's different ways, different approaches in all of these different areas, right, where we want to try to support that crucial variable that you bring out, which is compliance. And I think we've demonstrated in various sectors like schools and workplaces that it can happen. We got to expand that to other things like like driving safety and other key areas. But I do believe that it's doable. Crucial question, though, something we have to be thinking about all the time.
Excellent. Let me just remind everyone, if you have questions, please use the Q&A box in the bottom. David, you have any questions on your side?
Yes. I had another question. It's regarding a different project. So you talked about the Zimbabwe project ZEAL, where you use different innovative ways to actually assess children with hyperopia. So this is perhaps a question / suggestion of, have you recently, smartphones that come up, different apps, some of them have even come up with ways to actually do some sort of simple refraction using smartphones. Do you see that as a potential way forward to, kind of synergize your attempts to bring technology in for all these assessments?
Yes. So we work with Peak, and Peak Vision, is one of the organizations that has pioneered and been most successful with the use of smartphones. Peak has done some good quality RCTs, and I think that they have shown that in many settings, the use of their model, driven by the use of smartphones, delivers the main benefit of closing the loop more efficiently and driving much higher access and use of glasses. So it's just more efficient in doing what we're trying to do, which is get glasses onto kids' faces. And so I think there is a role, definitely a role. When it comes to the screening part, I guess my own feeling is we're looking at some things that are even cheaper than smartphones. Right. We're looking at things like, laser etched vision charts. I mean, those things are actually the resolution that you need, small enough optotype that a kid will find it challenging to see at 12 centimeters. Current resolution, even on my top of the line Samsung, is not there yet to deliver that. And you can't do it with conventional printing either, but you can do it with laser etched charts. And once you have the initial, cost, as those become more common, they're cheap, a lot cheaper than smartphones. So, yeah, I think smartphones are probably part of the solution. We're also interested in even cheaper and more robust things. Nobody's generally going to steal your laser etched vision chart, but if you're carrying around a bunch of smartphones as part of your team in Zimbabwe, I can tell you better have them nailed down. So, yeah, I think they're definitely part of the issue, part of the picture, part of the solution. We're also, though, interested in other, even cheaper things that may work better in some settings or work in complement with smartphones.
I think I know where David's coming from as well, Nathan, because in our pillar within the center, we actually are focusing on developing new devices for the detection of eye diseases in the community, and these are actually affordable, easy to use devices. And that makes me think that in most of your studies, but specifically for Clever, for example, for Thrift, there is a way we can collaborate for detecting eye diseases as well through some of our
I'd be very interested.
Custom-built devices. So David has a couple of devices. Associate Professor Victor Ko has a few devices. I have a few as well. So there's definitely room for collaboration here. I wanted to ask you that question. You have all these studies. What's the sample size for each of these studies? Because you have so many variables you're going to be investigating. You have so many potential confounders. So how do you manage to calculate the sample size for these studies?
Sure. So the great thing is RCTs. You know, the RCT design ray is such a powerful tool because if you have a large enough sample size, I would say these are mostly around between 400 and 800 is the sample size for most of these things. And once you get up to around 400, 800, and you're randomizing on an individual basis, not only are you going to know that you've balanced out the variables that you know about, but you've also achieved balance on the variables that you don't know about. And so there could be hundreds of things that have an impact on dementia that I don't know, particularly as a dumb ophthalmologist. So the trial design is incredibly powerful in helping us with those problems. Coming back to the issue about gadgets, I think that's a really crucial thing. And I'd love to see that collaboration strengthened. You know, Ray, that I'm doing some work with your newly designed global eye health team. And we've brought into the mix LV Prasad. They also have a strong interest in coming up with new devices. And because they have such a large network of outreach, there's the opportunity of, literally millions of patients being driven in. A couple of things we've been looking at on the device side, I'd love to hear what you guys are working on. We're interested in applying AI not only to glaucoma and diabetic retinopathy, which are quite widely done, but also for cataract. In a lot of settings, if you have the ability to train an AI to recognize a cataract, you take your team, your screening team, from having to include an ophthalmologist or an optometrist. And now you've got a screening team that's basically village health workers and a driver. So that's an area that we're extremely interested in applying AI to, looking at the identification of cataract, improving sensitivity, specificity, putting that into the hands of a much lower cadre of people. And then it'd all be a smartphone, basically. You have slit lamp attachments, you get the slit image off of this, and then the AI is resident there in the phone, either directly on the hard drive or available online. Another thing we're very interested in is visual field screening for glaucoma using virtual reality. So again, with smartphones and with these sort of virtual reality devices, you have companies, billion-dollar industries that have produced devices and technology just for us, and we didn't have to pay for them. Screening for the visual field using a $300 or $400 virtual reality device offers a number of real advantages. For one thing, instead of a conventional Humphrey visual field saying, I need you to look centrally the whole time and just notice a light, instead you can build saccades into the whole thing and have people use pupil tracking, have the individual do a saccade looking at the light, much easier for an older person to understand. Look at the light instead of try not to look at the light. And it's potential, of course, to take a $30,000 visual field device and make it a $300 device, and a device that I can carry 5 of them on the back of a motorcycle if I need to. So we're extremely interested in that application of VR devices for glaucoma screening. But there's a million things we could do. And I'd be very interested to have a discussion about some of the devices you guys are working on, potentially bring LV Prasad into it. Not only do they have their own device stuff that they're doing, but also, as I mentioned, because they've got this huge outreach network, there's the potential of using some of these devices, testing them, very quickly and inexpensively.
Excellent. To be honest, Nathan, I think you mentioned two devices that are probably also existing in our department as well. One of them is David's.
We should talk about it. We should definitely talk about it.
So let me ask a question Let me ask a question from the audience because we need to wrap up shortly.
Yeah, sure.
A very insightful presentation. How does the research program fits into the evolution of education system where the use of electronic devices is an upward trend? While one of the risk factors of myopia is, of course, increase in screen time. So this question is more focused on myopia and what.
It's interesting. The Ian Morgan likes to talk about this, and I think Ian's right. The rise in myopia that we saw in countries like Singapore and China happened well before the smartphone revolution. So I do think that conventional reading, also does a lot to cause myopia. So we don't have to have fancy devices to do this. Pretty much anything that you're using to learn from has the potential to cause myopia. So obviously, we're not going to tell people to stop looking at textbooks or computers. We have to have ways of either managing or treating myopia. We've done a lot of work on the issue of improving, strengthening myopia refraction services, screening, refraction in China, the strong, important area. But the work that we're doing together, Ray, I think is potentially game-changing. And in fact, when I go to China next week, it's one of the main things I'm going to be talking about is the red light therapy that we're looking at. The ability to create low-cost myopia prevention and to deliver that low-cost myopia prevention in a non-invasive way at schools, that to me is a societal game changer. That's what we've got to do. The current things that we have of ortho-K, low-dose atropine, that stuff is great for worried parents. And there's going to be educated people in Guangzhou, Beijing that are going to do that for their kids, and that's great. But if we want a social solution that's going to benefit every kid in China, every kid in Singapore, every kid in Hong Kong, that's what we got to do. We have to deliver it in schools. Part of that solution, of course, could be additional time outdoors. Taiwan has proven that works. 10 by R, daily 120. It's been successful. They've got an inflection point. They're lowering myopia in Taiwan after decades of rising. But unfortunately, that's not going to be consistent with high-pressured school systems in countries like Singapore and China. So that's where I think something like red light therapy comes in. The potential to do something school-based, 6 minutes a day. Every kid benefits. Every kid just sort of troops through and gets it done. You don't have to worry about compliance. Don't have to worry about the parents being interested or not interested. I think that's where the game changer is. So I'm spending a lot of my time these days thinking about red light therapy as a potential way of preventing myopia. We got to have some way of prevention that goes along with treatment glasses. We're not going to, as the world, myopia is going to become a bigger problem. We're all of us working together, WHO, UNESCO, to try to get kids into schools. More time kids spend in schools, the more myopic, the more likely it is they become myopic. And it's great, get them outdoors when we can, prevent diabetes, prevent myopia. But in situations where that's not practical, I feel like red light therapy is a really exciting opportunity. And I'm putting a lot of my time into thinking about that. So I agree with your question. We have to have novel approaches. I believe they have to be school-based approaches to benefit all of society to prevent myopia. Crucial part of the picture, I think.
Okay.
Thanks, Nathan. That really agree with you that we did something that is low cost, easily deployable, and scalable for the community. And going back to what you were talking about for cataract, and visual field monitoring, definitely we can have a deeper conversation offline about some of the devices that we are developing as well. Yeah. I have one last very important question to ask you. In fact, it's a two-part question. It is how long does it take for you to come up with the names for all your acronyms, and which is probably the hardest one in your opinion?
2 minutes, Nathan. We have 2 minutes.
Exactly. Let me tell you, first of all, I was on my bicycle and I came up with a new one, which I think is my best acronym. And I feel it kind of sets the seal on acronyms. It's alphabetic capers really annoy normal young men. So if you're quick on the draw, you see that's an acronym for acronym.
Yeah.
So I think that's really, you can't go any further than that. I love wordplay. I love languages. I think you got to have a catchy name. I'm a strong believer. We spend a lot of time on comms. The slide deck, the way it looked, you saw every slide had its own little logo. I think that stuff is important. Vision drives development, all that kind of stuff. So comms is very important to me. It's all about telling a story. And telling that story is not always about a Lancet Global Health paper. Sometimes it's about very simple stuff that people immediately catch, and having a catchy name is a big part of that. So I'm a very strong believer in comms as a part of the whole storytelling piece. So that was the first part, acronyms. And what was the second part?
Which is your most memorable acronym?
Oh yeah, I think the best. I'm pretty partial to clever and stable, those ones. But if you have me to choose one, it would have to be alphabetic capers really annoy normal young men. Acronyms. Where else is there to go in the field once you've done that?
Excellent. So once again, I think Nathan, thanks a lot for taking the time for this to give us this talk in our webinar series. I think the main message from today, I think if I summarize it in one sentence, is Eyecare goes beyond Eyecare actually. So thanks a lot for sharing with us all the information. So to all the attendees, this is a recorded session. If you want to see it again, listen to the talk again, watch the talk again, please go to our website. Also, I would like to highlight that the upcoming webinar is on the 13th of June, same time, 6:30, 7:30. We'll be having Prof. Kyoko Onomatsui, and it will be hosted by my colleague, Assistant Professor Tam Yi-chung. And I'll take a very brief time to advertise here for my own lab as well. We have an open postdoctoral position. So if you have an expertise in visual neuroscience, pupillometry, eye tracking, or have any of the qualifications below, feel free to email me or scan the QR code here to learn more about the position. So thanks again, Nathan, for joining us today and sharing with us all this very exciting work. We look forward to having you maybe next year again, so you can share with us the data.
That's great.
Right?
I'd love to do it.
Okay.
And I'm quite serious. I've enjoyed the work we've been doing together already, Ray. I
Same
would
here.
love to broaden the scope of our collaborations together. Love to hear about some of David's
I'm sure we can do that.
And I think potentially bringing LV Prasad into that, you have a very powerful three-way synergy. I think I'd love to explore those options. So thanks again for the invitation, and thanks for everybody's attention.
Thank you, everyone. Thanks a lot for joining us, everyone. You have a good evening. Thank you, Nathan.
Bye-bye.
Thank you, David. Thanks, Shalini.
Thanks, Ray.
Bye.
Thank you, Shalini. Bye-bye.